Hi, this is Kathy Kinnett. Thank you for joining us for this PPMD webinar discussing the nationwide Children's Hospital Carrier Study, what we know, what we don't know, and what we're hoping to learn about cardiac disease in female carriers with a genetic mutation. We're very pleased to be joined by our speakers from Nationwide Children's, Dr. Hor is cardiologist and director of the Cardiac MRI program, Dr. Ling Mah is cardiologist with the Adult Congenital Heart Disease Program, and Daniel Jenkins is clinical research coordinator for the Center for Gene Therapy and for the study. So before we start, just a few housekeeping points. Everyone but the presenters are on mute. So if you have a question, please type it in the discussion box. We'll try to leave all the questions until the end. And as with every webinar, this webinar will be archived and available for viewing later. I'd like to turn the presentation over to Dr. Ling Mah. Ling?
Hi, thanks, Kathy. I wanted to thank everybody from PPMD, Kathy and Danielle, for sponsoring this event and for sponsoring this study. Con and I think this is a great opportunity to share with you the study and update you all on a couple of things. Just as a side note, Con and Daniel will both be available after the presentation to answer some questions. I have a prior obligation, so unfortunately we'll have to go. But Daniel's contact information is available, so should there be questions after the meeting for me specifically, I'm happy to respond through Daniel. So to start, Con's in control of the slides. Con, can you go to the next slide? This is the official title of our study, and we've listed there the pertinent co-investigators that are working on the project, and we'll go into that in more detail kind of as we go on. So what we think we know about DMD carriers at this point is that only cardiac disease is really being demonstrated as a true manifestation. While skeletal muscle weakness has certainly been reported and diagnostically CK levels are used to identify carriers, what we've realized is that cardiomyopathy appears to be a pretty significant pertinent manifestation as well. The risk of this increases with age, as you would expect with almost all cardiomyopathies. Less than 16 years of age, there have not been any reports of cardiac disease other than some truly manifesting carriers, and I think that those patients are kind of a little bit outside of the scope of this talk. Between ages of 16 and 36% of patients are felt to demonstrate cardiac disease. Between 31 and 59% demonstrate cardiac disease, and then after the age of 50, about 15% are actually diagnosed with a dilated cardiomyopathy. The definition of the disease is unclear, and I think that will be a recurring theme throughout this talk. And for the most part, the diagnostic tool that has been used to diagnose patients with cardiomyopathy has been the echocardiogram. And that is starting to change, and we'll talk about that as we move on. Newer studies suggest that there is a higher incidence of cardiac and non-cardiac problems at a younger age than previously published. And so if you look at these, just kind of a smattering of a search of recent publications, this is kind of, not surprising probably to anyone on this call, kind of an evolving frontier. So how do we actually get here? So studies suggest that DMD carriers have significant cardiac disease, as we discussed. Treatment may be needed because there is an identified risk of cardiomyopathy, but that is clearly a question that is hanging out there. So we set forth to design a trial to both detect and to treat DMD carriers with cardiac disease and monitor those with normal cardiac findings. So I think all of us, when we started this, felt the need to do something. And, you know, Con and I are becoming less and less youthful. However, we were pretty ambitious when we started. And I think, you know, most of the people involved in this kind of work have felt that same impulse to basically start doing something. So this is where we started. We'll zoom in on the area that I think in hindsight was fairly premature and ambitious. We started with these flow sheets in terms of what our study proposal was going to be over a period of 2 years. There were 2 arms. One of them was actually going to be a treatment arm. We were going to randomize, and we were going to treat people by the American College of Cardiology, American Heart Association heart failure guidelines. We were going to gauge people by MRI. We were going to randomize. We were going to have a placebo treatment. And, clearly this was kind of a demonstration of our ambitions, and it was not necessarily wise. We were kind of putting the cart before the horse, to state it lightly. So we sought some sage advice, and we got it. We are very fortunate at AHY Children's to have Dr. Mendel. I'm sure you all know him. He is one of the foremost clinical trialists in the world. And so we went to him, and he was very kind to us. But he was said, maybe it would actually be good to start at the beginning. And so, when we started kind of working and collaborating with the neuromuscular folks, we really had to dial back, and we needed to be kind of reasonable about what our goals were in terms of the study. So unfortunately, this is where we are, and it's a tremendous canyon. And so we are kind of at a point where there is quite a bit that's known, and in large part that's based on a lot of Duchenne studies that are not dealing with carriers. And so we kind of are trying to piece together the information that we have and the studies that we've presented kind of to this point in terms of the burden of cardiomyopathy. But we're a good distance away from treatment, and that was frustrating at the beginning, but I had to acknowledge that the gap exists, and I think that I suspect that is a frustration kind of in the patient population. Is certainly a frustration in terms of the physician group. So, normally these thank you slides happen at the end of a study. We felt the need to put it kind of up front as a preemptive thank you. Mostly to the participants who are agreeing to participate in the study, because we recognize that this is a time commitment, that there is a potential that we provoke some anxiety in patients. There is the potential for findings, and there's no clear treatment benefit for now. We recognize that this is step one, and we're asking you to kind of take this big leap with us. Realize that, the idea of this is step one in what should be, hopefully, a long future of multiple steps. At the end of the day, we're hoping to get back to that first crazy slide of the protocol we proposed, where we're looking for the right treatment and the right time for that treatment. We don't know if it's before you present with anything at the age of 5 or until after you manifest at the age of 50. And so I think all of these questions are out there. I think the other thing kind of as cardiologists is that not all of these medications and treatments are benign. And so there is always the potential when you start out with something like this that to do the right treatment is, if we have the opportunity to do it right from the beginning, then I think we stand to benefit the group the most. So our real starting line is to ask a couple of somewhat straightforward questions that aren't that easy to answer. So does carrier cardiomyopathy exist? And there's obviously been work with this. What does carrier cardiomyopathy look like? What constitutes manifesting? And that seems rather simple, but it's not. And how prevalent are manifestations? And clearly this hinges on kind of the answer to question number 3. And so this is really where we are starting. So what is known? So is there really a basis for expression of disease of DMD in carriers? So some carriers do have a reduced production of dystrophin. There is something called X chromosome inactivation. You have 2 X chromosomes, and if there's inactivation of the normal allele, this can be associated with clinical manifestations. The bottom line is there is a genetic basis for the existence of true, for lack of a better word, disease in a carrier. So when we look at the heart in a DMD carrier, we have to talk about cardiomyopathy and what actually is cardiomyopathy. Cardiomyopathy is a fancy way of kind of maintaining job security for a cardiologist. All it is that something is wrong with the cell muscle. Cell injury does result in cell death. The chamber becomes thin and can dilate. That thinning, when we look at it on imaging, usually is scar and will show up as fibrosis. Over time, fibrotic tissue, I guess I could most akin it to like a tendinous type material, does not function as well as heart muscle, and so then the function declines. So what is the prevalence of carrier cardiomyopathy? And I think that this is was the hardest place to start. It all depends. So like we mentioned before, there is really no current definition of manifesting versus non-manifesting. And it depends on how you define a diagnosis. Specifically, what modality do you use to say, oh, this clearly represents disease or does not represent disease? So cardiac enzymes is something we'll discuss in a little bit of detail, echocardiogram or ultrasound, and then cardiac MRI. So our first task was to define carrier cardiomyopathy, and at the end of the day, we need to just design a study to define it. And when we looked at this as a big circle of unknown of cardiac disease, we realized that it is clearly multifactorial. And there are so many things kind of involved in it and that are overlapping. It's one thing influencing the other, that we started to put this together and said, you know, this is going to be a much bigger project than this is not just a cardiology study. So you'll see that we know that there's an impact of the diagnosis. We wanted to definitely pay attention to the psychosocial effects of both the good and the bad in terms of making a diagnosis or calling something a disease. Mostly, if you're going to call something like that and kind of have the burden of that, we wanted to know if there's going to be a lead time in terms of the impact for treatment. We wanted to know if there was a role for standard heart failure treatment in this patient population, and we wanted to acknowledge that a lot of muscle processes are compounded by age and also by acquired disease. Most specifically, what we're studying, I think everybody understands acquired disease as being hypertension and cholesterol and kind of all of the normal things that happen to you as you age, unfortunately. But most specifically, we wanted to know what the impact of your own health concerns, as well as caregiver stress, was going to do in terms of compounding what is happening at a cellular level of the heart muscle. So going back to the diagnostic strategies, cardiac enzymes, so specifically the troponin. Cardiac enzymes are widely used to assay ischemic heart disease, for example, heart attacks. Anybody who presents in this country, or really any country, to an emergency room with chest pain will have these labs drawn. These enzymes are present inside heart muscle cells. When we can measure them in a blood draw, in the bloodstream, they're a marker of cell injury. When cells are injured, they release these enzymes that should only exist inside the cell into the bloodstream. And then if you have a measurable value, then there is concern that there's heart muscle damage. CK and CKMB are also considered cardiac enzymes. However, because they are present in both cardiac and skeletal muscle, they are not too specific for heart muscle injury in muscular dystrophy. So troponin is really the one people are focused on because it is specific to cardiac muscle. And there are 3 troponins that are measured, which is troponin I, C, and T. There are case reports of elevated troponins and carriers with Duchenne. And I only show this one article because they do a nice review and on the next slide of all of the existing information in regard to cardiac enzymes. The largest study is blood from 129 DMD and DMD carriers. Not surprisingly, CK levels were elevated in a significant fraction. However, none of the carriers had detectable troponin I's, and only 2 carriers had detectable troponin T's. The mean age of the patients in this study was 37, and none of them had any symptoms or signs of ischemic heart disease, so the cholesterol coronary type heart disease. Troponin T was detectable in 1, but that patient had a pretty much normal echo. Troponin I was not detectable in any. And based on this 129 patients, they felt that there was no clinical correlation between heart disease and any of the cardiac enzymes that they measured. This same study also had EKGs and echoes performed on these 129 definite carriers. The echo abnormalities, depending on what you called abnormal, varied. 5% of them actually had evidence of what they would consider a dilated cardiomyopathy, and 5 of those patients actually did have signs and symptoms of heart failure. 18% had a dilated heart, and 13% were borderline. And these types of echo abnormalities are extremely minor. I'm not even sure that you would, borderline is probably a good description, but I would probably, if you were to go one side or the other, you would end up calling those patients normal. EKGs were done, and abnormalities were found in about half. A completely healthy heart by their evaluation, so that would be cardiac enzymes, EKG, and echo, was seen in about 40% of the patients in this study. MRI is kind of a new frontier, and Dr. Hor will talk more about this as we go on with the talk. But I will review just what we know in part about MRI abnormalities from prior studies. There is one retrospective study where they looked at 22 carriers and had MRIs on all of those patients, and 7 of them did demonstrate myocardial fibrosis. And so this is a substantial fraction, and so this was concerning that we were underestimating the number of patients with cardiomyopathy by the traditional techniques of EKG and echo, and certainly by labs. Out of the 7 with fibrosis, only 3 of them actually demonstrated heart muscle dysfunction. So while they had scar tissue on MRI, the heart muscle continued to squeeze just fine. And at worst, they had mild dysfunction. And so a normal ejection fraction of the left heart is about 60%. And so the lowest ejection fraction in the study was 48%. That would be considered mild. And so nobody had severe dysfunction on any of out of any of the women who had MRIs in this study. Interestingly, there have been other studies of 15 women who are confirmed DMD carriers, all undergoing MRI, and all of them had abnormalities by MRI. This study actually bothers me a good amount. If you look at the things that they measured on this study, they were fairly loose in terms of what they would define as an abnormality. Any one abnormality that they chose qualified them as abnormal, and it was a binary thing. You were either normal or abnormal, and a lot of these things are very borderline, including volumes and these small segments that may or may not look totally right. And so they said all of them had abnormalities by MRI. So I think depending on what criteria you use, you can make all carriers manifest. And so I think we have to be very careful about how we define manifesting. And it depends on the technique. And at the end of the day, what you're really looking for is what is actually relevant, either to the patient or to the treatment. And I don't think the answer to that is no. Stress and cardiomyopathy, we wanted to address as well. Going back to the image of the, cardiac disease, we do think stress does play a role. This has been demonstrated in other disease processes. So stress biomarkers are elevated among otherwise healthy young women who care for children with other significant challenges. There are other disease processes, specifically oncology and some behavioral autism parents that have been studied, and you can measure biomarkers in these patients and find them to be elevated. These biomarkers are linked with mitochondrial dysfunction. So mitochondria are kind of the building blocks of heart muscle. They store energy in heart muscle. And so these biomarkers, when they are elevated, are linked with mitochondrial dysfunction in the cells of the heart and theoretically could reduce the efficiency of heart muscle. So the question is out there as could stress accelerate a predisposition for cardiomyopathy? So then we moved on to task 2 after we had kind of defined the landscape and what we wanted to look. And so doing the study really ended up being taking all of these different pots and trying to pull them together into defining really what this cardiac disease was going to look like. So we sought to build a better study. Immediately, we recognized this was going to require a massive team. And so when we tried to pull all of these circles together and said, how do they overlap and how do they impact each other, this was going to be a team sport. And so we sought to compile our team. This is our current carrier study team, and I've clearly omitted a lot of people who are all very involved and very helpful with this. But we have cardiologists, dedicated exercise physiologists, a dedicated psychologist, and the neuromuscular team, Dr. Mendel and Dr. Alzadi, as well as Daniel, who's done an excellent job with the research coordination and interfacing with a large number of patients that we're talking about recruiting for this study. And so, it takes a village, and so we started with our small village, and we're trying to work each of these circles kind of in concert. So how is this study different from the other studies that I presented before? Well, firstly, this is a very large study. It's a case control study. So we would like to identify 150 definite carriers. We would also like to have 50 non-carrier DMD moms. And I think this is an incredibly interesting group to look at because of the stress question that we've presented in terms of caregiver stress. And then 50 control patients to define what is normal for a 32-year-old woman. That's not always a population that's really well represented in normal studies. They tend to be driven by older men. And so having 50 controls to compare to, I think, is going to be important. This is a longitudinal design, so we will be studying these patients yearly for what we hope to be about 5 years. And then the control population will also be very helpful in terms of defining normal parameters over that period of time. We want a holistic look at the patient. And so because of this is necessarily interdisciplinary. And the holistic look in terms of kind of how you live and where you are in life and what you do, I think is very important in terms of as it applies to all of the entirety of the disease. Treadmill testing is unique in that it has not previously been done in carriers, and we'll show you what that looks like kind of as we move on. And then technical improvements. Most of the previous studies have relied on EKG and echo. Those are not eloquent ways of looking at this. And there is obviously evidence that we're going to find more by MRI. Does that mean that all patients are going to have abnormalities? I don't think so. But the truth is somewhere in the middle between what we see by echo and what we find by MRI. And then within MRI, there are some novel techniques that Dr. Hor will discuss. In terms of what the study visits look like, it's a 2-day visit. Again, I go back to the commitment of this patient population in terms of agreeing to participate in this. Day 1 is a 4 to 5 hour day. It includes the biobehavioral measures, and we'll talk a little bit more of that in a bit, but it's a 90-minute kind of biobehavioral measure. And then the neuromuscular measures, which is about an hour, and then physical therapy measures, which is another hour. Day 2 is the cardiac testing. That includes a cardiac MRI with and without contrast, so that does require an IV. That cardiac MRI takes 45 to 60 minutes, followed by a break and a snack, and then a treadmill. The treadmill test also takes about 60 to 90 minutes. Now, to clarify, that is not running the entire time. The run is about 9 minutes, or the walk/run. But in total, it takes about that time to get set up. Study visits are all happening at Nationwide Children's Hospital at present in Columbus, Ohio. And there is some funding available to assist with travel and lodging expenses, as we wanted this to be an inclusive study for everybody who could do it. So to discuss the specific components of the study in a little bit more detail, the psychosocial component is, I think, an important piece of it. So there are really 3 aims, kind of the psychosocial portion. We wanted to establish what the cognitive function baselines are among all the carriers. We wanted to examine the relationship between stress and the cardiomyopathy, as well as the neuromuscular symptoms. And then identify themes in the experience of caregiving and carrier status among the mothers. And I think that's unique and important. So to break these down, the cognitive function is a very standard battery that everybody uses in most testing, and it's not particularly strenuous. I think it's just baseline testing. The stress component is a combination of surveys and then some unique and some non-unique physiologic markers. So the non-unique ones are inflammatory markers, and so these are very routine markers of inflammation. The unique one is a hair cortisol. So this does require a small clipping of hair kind of from the back of your hairline, kind of usually from about the nape of the neck or a little higher than that. And what we can measure is kind of a long-term marker of stress. If we drew it from your blood, it would kind of be that moment in time, and it changes on an hour-to-hour basis. But in your hair, you can actually measure how much cortisol is there and how much stress kind of in general has been present kind of over a period of months. And so we found this to be an interesting technique to evaluate for that. And then the final step is interviews. And so the patients are asked to respond to 3 prompts about being a caregiver and genetic carrier status, as we feel that this will likely impact the global health as well. The treadmill exercise testing. Treadmill testing is a very typical diagnostic test that we use to define functional capacity in patients. It is most often used to exclude ischemic heart disease, and so if somebody's having chest pain and you wonder whether they might have some coronary disease, that might explain that. A treadmill test is fairly common in that format. We thought it would be helpful for carriers because carriers are highly functional patients. Some of them can easily outrun me. Not that that would be hard, but I've been very impressed with how functional a lot of our patients have been. Treadmill exercise testing adds value to the traditional 6-minute walk, I think, that all of you are familiar with, because I think a 6-minute walk isn't going to be able to discriminate how functional someone is at a much higher level. And I think it's going to help define those with and without manifestation in a real functional way, not just imaging. It also offers very detailed information on your hemodynamic response to exercise, blood pressure, and heart rate are all measured, as well as your effort. And I will say that I've never seen so much effort in a study population in general than I have in the 30 patients we've tested so far. So I think I've been told that the treadmill is intimidating to some patients, and so I wanted to break this down some. So the first thing we do is we set you up. You do get attached to an EKG, so the stickers that get put on your chest and some wiring that gets strapped around your waist like a belt. And we put on a very lovely face mask. After we put on the face mask, there is an obligatory selfie or a Facebook post that usually happens. If family is there, that usually results in some laughter. It is a funny-looking mask, but it is soft. It is not as uncomfortable. We purchased this mask specifically. It's a very comfortable mask in relative terms, but it will measure inhalation and exhalation during the entire study. Then we ask you to run. On average, it's between about 6 and 10 minutes, and obviously we tailor that to the person doing the run. And then the last part of this is the data collection. So these are pictures of the 2 screens that we have during the treadmill testing. And so one of them is an EKG on the left. And on the right, there are some higher measures in terms of that mask, in terms of what we're getting in terms of inspired and expired oxygen and CO2. So this next slide, we wanted to play for you, and it looks like it's going to play slowly, but what it actually looks like. And so the 2 people in the slide, so Michelle Slowinski is our exercise physiologist, and she coaches people through all of this, and she has the perfect personality to do this. The woman running is actually one of our cardiology research nurses who has offered generously, I think, not only to be a control, but then to also do this treadmill for us to test it. We've recently purchased this new treadmill equipment, and so we've been working it out. I don't know if you can tell kind of in terms of the speed, it really is kind of a speed walk through stage 2 and then a very brief run. We try to get at least 30 seconds of run at the end. And so I don't want people to be intimidated by this in terms of as a portion of the study.
So my name's Khan Ho. I'm one of the pediatric cardiologists here at Nationwide Children's Hospital, specializing in cardiac imaging and working with Dr. Kreit and the team here on many different types of neuromuscular disease. We obviously focus on the Duchenne population. So how do we detect your heart? So we check this in 2 common ways. Echocardiograms, as you know, is something that's very common. It's available. And then the more advanced type techniques would be a cardiac MRI, which many of the participants, their sons have gone through, and many of the participants have gone through as well. So in assessing the heart in patients, especially in the carrier population, as well as in a Duchenne boy, MRI is superior to echocardiogram. In this example here on the left screen, I know it's a bit jumpy. What you can see is the heart function is normal, and then on the right screen, the heart function is abnormal. And these are clearly where you can see on MRI much better in echocardiogram. But we really want to go beyond just looking at cardiac function. We need to assess the heart beyond global heart function as assessed by ejection fraction or shortening fraction, really going with more novel techniques. This is not comprehensive, but just for the a little bit of show and tell, we can look at your ventricular morphology, what your heart tissue looks like. It's a phenomenon called left ventricular non-compaction, and I'll detail some of this in the subsequent slide. And we look at what we call myocardial tissue characteristics, what's happening to your heart by a process called late ganglion enhancement, which we can look for scar, as well as more novel technique called T1 and T2 mapping. These actually allows us to look really at microscopic levels of your heart disease for the process of scar formation that cannot be seen by traditional techniques, as well as for any type of ongoing inflammation. And then one of the mainstay of interest is really looking at your ventricular mechanics using a technique called myocardial tag imaging for myocardial strain assessment. This technique allows us to really get into the basics of how the heart muscle itself works. So in the next subsequent slide, what I'm going to do is give you a little bit more detail into what's going on here. So left ventricular, looking at ventricular myocardial tissue characteristics, left ventricular non-compaction is really characterized by these what we call deep trabeculations, as you can see in the sample slide here, with all this almost like a spongy looking piece of tissue here. And on the schematic that you can also see all these little crevices. It's been known that this is actually a form of cardiomyopathy that can be happen in general population, but it's been known to occur in both the boys with Duchenne muscular dystrophy as well as carriers. This study aims to define better the prevalence of left ventricular non-compaction in carrier because that is a risk of cardiomyopathy. So one of the important mainstay of looking at the heart tissue is called myocardial fold fibrosis. It's done by a technique called late ganglion enhancement. What you can see is on the left screen, on the top is a DMD patient. The carrier and the boys have exactly the same pattern of fibrosis. What you can see is the outside of the heart muscle is affected. Even in this advanced cases, the inside part of it is not affected. This is different than a patient with heart attack where you can see that the brightness actually happens on the inside and actually spares the outside part of it. And this has actually been shown in comparison to what we consider a pathologic specimen and then shown microscopically by these blue stain here. So we know that in the Duchenne boy, it's a precursor to ventricular dysfunction, and we know that early detection may lead to early treatment. And in fact, this is happening for the boys. For the DMD carrier study, this will be an important aspect to really further define how many patients have it in a large study and really help us tie this all together with a very comprehensive evaluation that's being done by the team here. So ejection fraction essentially measures the global state of how well the heart squeezes, and this is a late finding, and this occurs in many diseases, but in particular in neuromuscular disease. So tag imaging is really a more sensitive method that's been shown in many different diseases, including many of our studies in the Duchenne boys. And what it really allows us to do is detect cardiac dysfunction earlier by a phenomenon called myocardial strain, as shown by this image here towards the end called tag imaging. So, why is this study important to DMD carriers in boys? So really, at the end of the day, improved outcomes requires better proactive treatment strategy. Unfortunately, the methods that have been used has been a barrier because it lacks sensitivity and it's not specific. So you really can't use it to not only to detect treatment, but you can even detect disease. So myocardial strain is something that we've been using in multiple clinical study as well as in trials. It's been shown to be more sensitive indicator of cardiac function way earlier than ejection fraction. This combined with the other findings that we discussed with the fibrosis as well as the left ventricular non-compaction will give us a much better understanding of someone's disease state. And this will lead us to the next step for consideration of treatment. So why might carrier DMDs provide clues for DMD boys? Well, the question is, does this represent a less severe state of DMD? We also know that congestive heart failure treatment therapeutic may impact on more measurable parameters that we discuss. and we can test longitudinal therapies, and we have performed stress evaluations that will help show us the impact on stress on your heart disease. And this is much more feasible in carrier population than DMD boys due to the significant skeletal muscle disease, making it difficult for the boys to be able to do appropriate exercise tests. And in addition, the disease in our carrier population is a much slower process. So all this stuff put together really have important implications for future trial participation. So, well, where does this all leave us? Really, at the end of the day, we are trying to bridge this gap here with really our two foremost experts here, with Dr. Kripe, who's been really a passionate pediatric cardiologist who's well known all around the world, and Dr. Jerry Mendel here, hanging out at the edge of the cliff, really bridging the gap, and we're very fortunate to have them help lead our group to better define carrier disease in all aspects. So this is just a quick update on the carrier study so far. Our goal is pretty lofty. We are shooting for 150 DMD carriers with 50 non-carrier moms or boys with Duchenne muscular dystrophy, and then 50 control patients that have no known children with any neuromuscular disease. So each participant will have a baseline and follow-up studies as detailed earlier. Certainly Daniel can give you more detail if you have questions at the end. So far we've had 29 DMD carrier participants who have completed the initial study, and the feedbacks we have received have been very positive to date. I know it's a long commitment for everyone, especially if you're coming from long distance, but I think the value is important. We're currently putting the data together in this comprehensive study. So really, at the end, your participation is really vital to the success of helping us better understand how to care for you better. So look forward to the next announcement on the next webinar, which at the Nationwide Children's Hospital Duchenne Muscular Dystrophy Carrier Study. This will be part 2. Some sage advice from Dr. Mendel as well as the rest of our team. We'll cover some of the parts of the study that was not discussed in detail on today's study. So if you have any questions regarding participating, please feel free to contact us, whether it's about participating, how to participate, travel, fun. Daniel has been a very important component in terms of working to help get everything set together, along with the rest of the big team that's really been behind the scene. And we clearly have not acknowledged everyone that's involved in the study, but Daniel has been the person that has been dealing with many of the questions and help coding everything for our team so everything runs as smooth as possible. So it's really important for us to really appreciate do the study, and we like to acknowledge the fact that it's a lot of commitment for a lot of the families who come here to participate in the study, especially when you're coming from long distance, and also really putting your fear aside of finding out something and not being able to do anything with it yet. But this is the first step to really getting a better understanding of your disease process so we can move to the next step of treating you. So obviously this cannot be done with a really large team, including neurology, neuromuscular, many people from cardiology, and many other colleagues throughout NCH, including especially the research team. And then first and foremost, parent Project Muscular Dystrophy and all the folks there with Kathy, Pat, and everyone else. Without this type of support, we would not be able to do this. And also, we'd like to recognize the Heart Center for offering a small intramural fund to help us really start the pilot study to move this process going forward. So for this, we'd like to thank you very much for listening in, and we are more than happy to take any questions.
Thanks, Con and Mei-Ling. That was really wonderful. That's great information. I'm sure that everybody really appreciates it. So one of the questions is, how are the 150 carriers ascertained? How do they join the program, and how have you decided who can join? Is it just anybody, all comers?
Yes, so this study is for anyone that is interested in the study. We are not localizing to any specific part. We want this to be comprehensive because we understand that because this is a single site study, for the sake of being able to reduce costs and try to get as many participants as possible. If you're interested in, we have patients so far who've come from all over the country, And I know travel is a little bit of an issue, so we have found some funding through PPMD as well as locally here to at least help offset some of the expense of it. So yes, everyone is more than welcome. And what we do is, if you have a son who has Duchenne or Becker, you're more than welcome to contact Daniel, and then we actually will do a whole comprehensive test. This includes genetic testing along with the many things that we had shown earlier.
Okay, so if you want to participate, one of the requirements is that you have a child with Duchenne, right?
That is correct.
And if you haven't had genetic testing, then genetic testing is part of this program, correct?
Correct. Whether you have genetic testing or not, you will get a confirmatory genetic testing. We want to be very consistent because not all genetic testings are done in the same way. We are using a very specific lab that is doing all our patients, that is being used for Duchenne boys as well. So we're using the high-level type testing so that we can confirm 100% exactly what it is. Plus, we have expertise here with Dr. Mendel and the team who can interpret what these tests mean, what the results of these genetic tests means.
Okay. Are there any other exclusion criteria, Con? For example, if someone has a heart condition or a pre-existing condition, such as a heart condition, does that exclude them in any way?
At this stage, what you do is you can still answer the questions if you're interested. There's a whole series of questions, and so far with all the participants who have contacted us, there has not been any. So we would suspect that if you had structural heart disease or something that would be contraindicated to exercising or to the MRI, then obviously you would not be able to be part of the study, at least at this stage, due to the contraindication of being an MRI. But to date, I do not think there's anything specific. I think if you're interested in at least finding out, we will profile for you a question that will help us determine whether it would be too risky for you to be part of the study. And if you have significant heart disease, you'll either we would refer you to your cardiologist that would treat you, or if you want to, we also have expertise here that can see you clinically as well, because we don't want to, for carrier patients to have significant disease and be ignored. We want them to be addressed, because if you have disease, then we actually want to be able to help you.
Okay, so they will complete the questionnaire, and then you'll screen them and make sure that it would be safe for them to participate. And as long as it's safe for them to participate, then they would be appropriate to participate, right?
That is correct, because the goal of the study is to understand the whole disease spectrum. We want to be able to really, unless there were significant contraindications, which are pretty minimum, we want to understand from the early stages to the late stage. I think the only way to be able to get a better sense of how, through the ages, what your heart looks like, along with all the other things that's happening to you, we are welcoming anyone who's interested in, as long as we're able to make sure that you're safe. That's the key part of it, is that we want your safety to be the priority when you participate in this study.
Okay, I've gotten another question about being a carrier and participating, so I just want to clarify that if you have a child with Duchenne, whether or not you know whether you're a carrier or not, you're able to participate in this study, and carrier testing will be a part of this screen. So wanted to say that one more time.
That is correct.
Okay.
So as long as you have a child, a son with Duchenne muscular dystrophy, you qualify for the study.
Okay. And this study is registered on clinicaltrials.gov, correct? And I know that it's in the clinical trial, find a clinical trial tool that we have available on Duchenne Connect, but I just wanted to make sure, is it registered, Con?
Let me verify with Daniel. If not, we will make it happen.
Okay, I'm pretty sure it is.
Clinical trial.
Okay, I thought it was, yeah. Okay, thanks, Daniel. And Daniel, do you have a son that's going to some other clinic for Duchenne care? Can they continue to go to that clinic for Duchenne care, and the mom can come to Columbus for the study?
Yes.
Okay, so patients will continue to go where they normally receive care, and moms can come to Columbus to be part of the carrier study. So.
Yep, that's correct. And results
okay.
from the study procedures can be provided to, where the moms might be receiving care as well.
Okay. And at this stage, Con, we're not involving sisters or grandmothers who do not have sons with Duchenne. Is that correct?
Correct at this stage, because I think it's an important question. We want to be able to be inclusive, but one of the most important component of this is really, moms. Kudos to all the moms, who take care of the boys. It's an amazing population of families. Through my many meetings with people, with the family members, and one of the most important component that makes it very important that it is the mom is the stress component of being a mother, the care of having a son, that you're taking care of, and that you're sacrificing yourself, your health and all the stress that goes on. And we know that there's an important stress component related to being a mother, who takes care of a child with significant disease that you put a lot of time into. So this is why we have restricted at this stage to moms only. Now, in the future, obviously, there are important aspects of those who are carriers who are not necessarily moms, but sisters or grandmothers or mothers who have had children who have unfortunately passed away. Those are important. We want to be able to answer a question to help to better treat all carriers, whether it's moms, sisters, or grandmothers.
At some point, right. And as Mei-Ling said at the very beginning, I think that the first part of the study, this 150 carriers, 50 controls, and 50 non-carriers, is an effort to really clarify this manifestation of this disease within this population. So I think starting with the Duchenne moms is the idea, and then being able to branch out to other female members of the family is thought to be the next step, right?
Absolutely, and that's an important point because I think it's really important to know what it is, how much disease there is, because you have to deal with, how should I get testing? How often should I get testing? And if I have certain things, should I be treated? So at this stage, all the studies that have been done have been informative, but they really have not addressed comprehensively, maternal carriers, the carrier mom as a person. Everything has addressed its very specific things. So I think to understand the whole disease aspect, from the stress to the genetics to the exercise capacity, as well as the cardiac MRI findings, those individually are very informative, but I think together will give us a really important basis to start how to consider treatment. Now, one important point to know is if we had an MRI on a mom who is participating and the ejection fraction is below a certain level that meets criteria for any patient, we obviously would be treating you with that. We wouldn't just observe you. We are observing this over time for patients who have disease but don't have indication for treatment based on today's practice. So that's why we haven't moved into the treatment. But if you do have significant disease, we actually would treat you.
Okay, that's a really important point, because in most clinical trials, you don't receive the information from the clinical trial outcomes that are gathered, but you're saying that if you find out, if there are abnormal findings, that those will be shared with the participants?
That is correct. Now, abnormal findings in that you need treatment. We are in a process as a group. It's very important for us to be able to contribute the information to the participants in a way that's helpful for them as well. At this stage, what we are trying to do is we're trying to understand disease first. What we want to know is if there's significant disease, we want you to know if it needs treatment. If you have disease, but it's just, these are based on the things that have been found before, we have not initiated any treatment or any discussion yet. We as a team is in the middle of discussing how we get information to the participant without affecting the quality of the study. It's very important that because of the stress component and the longitudinal component, that we are able to observe someone throughout the whole study. But at the end, we would like to be able to get the information to the participant because at the end of the day, that's the most important aspect of why we're doing this, so that we all understand the disease better. Obviously, we ask for your patience at the moment as we're trying to collect information that individually we can answer certain questions, but we won't be able to give you the whole details of it. But if you do have something that needs treatment, we are very aggressive about making sure you know about that. So if you have participated and we've not contacted you about your findings, that's because the findings that we have are not outside of the expected findings for being a carrier.
And they don't require treatment at this time, correct?
That's absolutely right. That at this stage, there's no data that would support that you need treatment at this time, and we would like to observe you, see how it changes in your next follow-up.
Okay, thanks. Are ICDs or pacemakers a contraindication to participation?
So in this case, one of the mainstay of the study is a cardiac MRI. So unless you have an MR conditional ICD or pacemaker, we wouldn't be able to put you because it would be unsafe for you to do it. So, again, if someone who is a carrier who's very interested in, you certainly can contact Daniel, and we can go through the process of finding out what type of pacemaker you have, and if it's one that is safe, we would be able to consider that. But typically, based on what we know so far, I'm not sure that there's, if you had a pacemaker ICD, something more significant would have happened to you, and we want to make sure you're safe. So I think the number of carriers who have this may not be high, but but we would welcome, if you have questions, we could at least look into the process a little bit more for you.
Good. And I think one of the things that we're hoping to identify with this study is the reason, or whether the reason that the ICD or the pacemaker was needed was due to manifestations of this disease, right?
Absolutely. So if you look at, there's a disease called hypertrophic cardiomyopathy. We know in that disease, when you have a significant amount of scar, the risk of certain cardiac event and the risk of arrhythmic events are high. So they've been using scar burden as a way to consider ICD placement. So what we want to do is really want to be able to find out more accurate information about a disease as a carrier, and then really find out how many people have it, what you have, what the stress component is, how does your genetics come into play.
Okay, thanks. Daniel, do you know how many people that are enrolled right now, and whether you still need non-carrier females with sons with Duchenne and still need controls?
I can tell you that we are seeing our 30th patient tomorrow, and we are still enrolling in both those cohorts, both the confirmed carriers as well as the confirmed non-carriers.
Okay, thanks. And are there age parameters for those two groups, for the controls or the non-carrier moms?
Just as long as they're 18 or older.
Okay. All right. Mei-Ling had mentioned that you were looking at biomarkers to evaluate stress, and
yes,
but she didn't say what that biomarker was. Was that the cortisol in the hair, or?
Well, there are several. So there are what we consider typical inflammatory biomarkers. So we know that in many disease, I won't go into details. There are a whole host of profiles of what we call inflammatory, that things that are in your blood that we collect that are elevated. That's a traditional way of how people look at. Cortisol is a known stress, hormone that is elevated when we're all stressed. Now, the reason we collect it from the hairs, and Mei-Ling says, is that it actually is a long-lasting. It's showing evidence of stress over time, not just because you had a bad day. So I think that's going to be very important. We know that in many different diseases, whether it's congenital or acquired heart disease, stress is a very important component of the impact on your heart. So whether it's just psychosocial stress, the anxiety, or really the stress of just having a child with significant disease, neuromuscular disease that you're taking care of, those are important. But that's a great question. So yes, there are many what we consider traditional as well as the cortisol stress test.
Thanks. Daniel, I know that a lot of people have questions about the travel grants that Nationwide has. Can you talk a little bit about what those are and how people can apply for them and what they might cover?
Yeah, sure. So it's not so much an application process. It's a reimbursement through the study. So what we've been doing is ask people to reserve their own travel, and they do pay for it up front, but then we are able to issue a check for reimbursement following the conclusion of the study visit. For most patients, for all patients so far, we've been able to compensate at least the cost of travel. So we've had people come from California and from Texas or from New England, and we've been able to cover their plane ticket in its entirety. And then beyond that, for a lot of participants, we've also had money left over after covering the plane ticket to afford a couple nights of lodging in a hotel near the hospital, so that we're trying to minimize out-of-pocket expenses as much as possible.
Okay, thanks. So if people are driving, have they been covering most of their expenses, and then you're helping with hotel, or are you covering gas as well as airfare?
Yep, we would cover gas as well. I think it's for the state of Ohio, it's like 52 cents per mile that we can reimburse.
Okay. And then are the hotels, are you lodging at the hotels using those for lodging or using Ronald McDonald and are you guys taking care of those reservations or are parents doing those?
For the hotels, largely we've been using a Holiday Inn Express right by the hospital because we have an agreement with them for a discounted rate. Because we have that discounted rate, I've been taking care of those reservations because to get the discount, it has to be reserved through the Welcome Center at Nationwide Children's Hospital. So for a general study visit, typically the participant will book their travel if they're flying or they'll drive themselves and we'll take care of the lodging.
So you guys really are doing as much as you can to involve and include as many moms as you can. So thanks so much for doing that. Yeah. Connie had one other question. You mentioned the word trabeculations, and I think that's probably a word that most people on the webinar aren't familiar with. So could you talk just a bit about what that means and the significance of that as well?
I think that's a great question, Kathy. So when the hearts develop, in everyone, it is not very tightly put together. So you can imagine it's almost it's like a spongy type looking muscle. Over time, all that muscle in the left heart starts to be very, very tightly packed together because it really needs that. In some patients who have specifically known left ventricular non-compaction, that's why it's called non-compaction, meaning that the heart doesn't get compacted down, so the muscles have a lot of these crevices. So it's just a description. So we use the word trabeculation, means that it has a lot of, when you feel it, it feels really rough compared to the smooth edge of that. We know that in Duchenne boys, a proportion of boys have that. We know in some case reports, some of the carrier moms have been shown to have that as well.
Okay, thanks. So normally you can find those those are just sort of grooves in the muscle where the muscle isn't put together real tightly, right?
Absolutely. That's a great way to say it.
And it's kind of somewhat normal on the right side of the heart that just pumps it along.
Correct. Not correct. In the right side, the muscle is not as tightly packed, whereas in the left heart, it should be much more packed. So I think your point of saying it looks a little bit more like a right heartish type picture is correct.
Okay, and that muscle doesn't pump as well, doesn't function as well?
So in some patient it doesn't, and in some patient it still functions normal. It is just a indicator that your heart muscle is probably not put together the way it should be. And then on top of that, if you have being a carrier, your risk becomes higher.
Okay, so it would be a finding, but not necessarily a finding that would affect the function of your heart.
Correct.
Okay, great. All right, I don't see any other questions. So, Con, do you have anything else that you'd like to say before we sign off?
Well, yeah, I think I'd like to thank everyone for listening, and I think all the participants, and I know that we'd like to encourage everyone from different parts of the country to participate. We want this to be very comprehensive. And we, this is a way for us to help understand where you are so we can actually help take care of you because you've committed your life to taking care of your son. So I think it's very important for us to be able to help you in with that aspect of it. And if you have questions, definitely feel free that we were not able to answer. Daniel will find us through emails, and we will answer the questions through Daniel and then through Kathy as well.
Thank you so much. Daniel, any last minute words?
I don't think so. I just want to thank everyone for their participation and their patience and putting up with me. We get a lot of emails, so if it's a couple of days before I respond, never hesitate to send me a reminder or anything.
All right, thank you so much. I want to thank all three of our speakers, Mailing included, and for everything that you're doing. This is an extremely important study, and we're thrilled to be involved in it. We can't thank you enough for your participation, everybody that's on the phone and everybody that's been involved in the study. So thanks, and we'll keep going and stay tuned for part 2. Thank you so much. This concludes our webinar.